Well, good evening. I see that folks are filtering in, so we're going to begin. Begin by warmly welcoming all of you to our fall speaker series event for tonight, Type 1 Diabetes Mellitus, Medicine and Humanism. Our keynote for the evening is Dr. Ricardo Correa. Let me go over our agenda for the evening. So we'll do some welcome and introductions, and then we'll have Dr. Correa's featured talk. And then at the end, please definitely save your questions or add them into the Q&A and we'll return to them. I'll be able to moderate some of those questions that you have, and then we'll share with you some exciting upcoming events in this series. So I am very happy to host this event. I'm Dr. Jen Hartmark-Hill. I'm the director of the Narrative Medicine and Health Humanities program here. Hopefully some of the attendees are our Certificate of Distinction students. For those of you who aren't familiar with that, we have a 4-year certificate track in health humanities and looking at ways to introduce humanism and to really marry the art and the science and have very person and patient-centered care. And welcome to all of our faculty, students, and staff and community members. We're really excited to host this event. So just as first item of business, I just want to share that we are located in the Salt River Valley, and that is traditionally home the ancestral territories of Indigenous people, including the Kimmel O'odham and Peepash Indian communities. And we want to respect that their care and keeping of these lands allows us to be here today, and that the U of A is very committed to build sustainable relationship with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. And an artist acknowledgement. So Dr. Zirulnik is here on the line. He's one of our panelists. You'll be able to ask him questions. But to contextualize this event is his narrative art exhibit that lives in the lobby of the Health Science Education Building, at least through the end of the month, that has really inspired and garnered a lot of the momentum around the various events that we're holding. So if you haven't had a moment to stop and take a look at it, please do while it's here. It will become a traveling exhibit after this, going all over the country, and welcoming, inspiring dialogue and bringing people together in community. So we did have a launch event prior to this and shared in detail, but we do have the artist and also our bioethics and medical humanism faculty member here with us as well. And so to introduce our speaker for the evening, I'm really pleased to introduce Dr. Ricardo Correa, who is a colleague and I consider a friend. We get to collaborate in a lot of different areas. He's very well known to our students, super supportive of them. And I like to tease Dr. Correa that he has more letters and degrees after his name than exist in my entire name, which is so amazing. He's so accomplished. We're so fortunate to have him here tonight. He is an associate clinical professor of medicine, and he's also the program director of a fellowship in endocrinology, diabetes, and metabolism. He's a director of diversity on graduate medical education and a health equity fellowship. He's faculty member with Creighton School of Medicine and clinical staff and researcher with Phoenix VA. And then just to highlight, so these are the very short highlights. You can only imagine how long his CV is, but just really wanted to acknowledge his extensive education. He went to medical school and a master's in education from the University of Panama. He did a fellowship in epidemiology and tropical disease, and then did a internal medicine residency at Jackson Memorial University of Miami. He did another fellowship in endocrinology with a neuroendocrine focus at the National Institute of Health. And I just so love this fact about one of the highlights that he's well known internationally. Nationally, he has many leadership roles, but he's very active locally. He's the medical director of the Patch Clinic, which is the Phoenix Allies for Community Health. I put the link on the slide in case you're interested in reading more about that or getting involved. They do really good work for people who are vulnerable populations, working poor, just need primary care and help. And so he also is involved in terms of community service with Camp Possibilities, which he'll talk about a little bit later. And then just lots of leadership, lots of scholarship, over 75 peer-reviewed publications in medical education, endocrinology, healthcare disparities, the editor of 2 books. He's on the editorial board of many more journals. And so please clap where you are, make some noise. We won't necessarily hear it, but just kind of send out those positive vibes and welcome our keynote speaker for this evening, Dr. Ricardo Correa. And with that, I'm going to stop sharing and allow him to bring up his slides. Dr. Correa, thank you.
Thank you so much, Dr. Hartmark-Hill. It's a real pleasure, first of all, to see you and see Dr. Zirulnik here, and thank you first for the opportunity to talk about this topic and to share a little bit of my experience on this, and definitely at the end some questions. So really appreciate it. Thank you so much, and thank you so much for the introduction. So let me start sharing my screen. Okay, so first of all, we're going to talk about focus more on diabetes type 1 because usually the most common thing to talk about is diabetes type 2, and at this time I think that the most appropriate, because we are going to see from kids to adults, it's diabetes type 1, and see what are the things that are happening in this area, and then what are the things that that all of us can do to help this community. So first, I want to start with when I really realized what is diabetes. I was an endocrine fellow at NIH, and really we were seeing the clinical part of diabetes. But it was not until when I was a second-year fellow that I had the opportunity to go to a diabetes camp. And during that time, I really had the opportunity to understand what a diabetes is, being in touch with this bunch of kids. And this is where Dr. Hartmark-Hill mentioned, this is Camp Possibilities. There's multiple diabetes camps across the country. This especially is in Maryland, and it's because I was in Maryland, this is where I went. But then I realized how difficult it is to be living with diabetes, but how life give the advantage to this kid to just overcome that. And there are highs and lows, but at the end of the day, there is happiness, and you can see how you control yourself. Also, I understand here the parents of these kids that during that, it's a 1-week camp, and we are on call one night of the week, because there is a lot of other providers, but in that night you cannot sleep. And always I think about the parents of the kids that cannot sleep 365 days because they have the kids with them. So it's so important to also realize whenever you see a patient what is behind the face of the disease, and going to these camps or going to other things where you can talk to patients really make you realize and make it more empathy to start with them. So here you can see in the pictures that I'm presenting. So one of the things is the entire camp. So you can see kids from the age of 7 to the age of 15, and then there is a post camp 16 to 18, and then they become counselors. So there is a big bunch of group that goes from very small kids to adolescents to adults. And then some of the campers just showing their different technologies that we are going to talk. And the last one is, this is a 1:34 a.m. and we are ready to shake the 2 a.m. morning, 2 a.m. fasting glucose. to see who develop or not hypoglycemia. And this is very intense because you have to go to all the cabins of the camp. So it's a nice experience, but the most important thing is an experience that make you realize and understand a disease from the standpoint of the patient, so you can get more empathy with them. And I want to put this video so you can hear from them what they think about this camp and what they think about living with diabetes.
It's the week that makes your world, you know, it's the week that you look forward to. For some people, when they hear diabetes, they think, oh, you can't have that food. You have to have special food. People here understand that, and they don't treat you any differently because everybody here has it, and you're just another kid.
There's a lot of people out there fighting the fight, trying to find a cure. But camp is what we can do now. This is how we fight now. Here, we're all wearing tank tops, and our pumps and our monitors are seen by everybody, and kids are yelling out their blood sugar. The ability to have fun, but also the ability to be with people who are going through the same struggles that they go through day by day, minute by minute. It's freeing.
I just feel happy that for 5 days a year, I'm with a bunch of people that suffer through the same condition that I have.
The second you get here, you don't feel like, ooh, new people. You kind of immediately just like relax. It's
it's kind of got this really homey aspect. Like you come here, it's like your second home.
I think it's just nice for people who like especially don't know anyone who has type 1 diabetes in their regular lives. So it's nice to come here and it's like a little bubble of family. Kind of the unofficial mission, or at least in my mind, of camp is that as much as we can, this is just supposed to be a normal summer camp that's adapted for kids with diabetes. And so much of the education comes from just being here, from being around other people with it, from seeing people older than you with it.
At my school, I'm the only person that has diabetes, so I feel different, and I always have to go to the nurse. I like it here because you don't have to feel different. You know that you can feel the same because everybody else around you is the same.
I come here and I literally walk down the driveway and I'm home.
We are really lucky here at camp that we have so many medical volunteers. We have nurses, nurse practitioners, physician's assistants, and then of course medical doctors that work here, that stay and live here on camp 24/7 for the entire week. We have had so many volunteers and our numbers keep growing, and people keep coming back because they enjoy it and they love being with the kids and giving them this opportunity, you know, to have a week of fun and also be safe while they're doing it.
I like hanging out with my friends in the cabin.
I like that.
Yeah, it's awesome.
Gaga.
Gaga's
a big sport.
I like the art barn, swimming, art barn, and just kind of playing around in the cabin with my friends.
The fishing, I like going to the pavilion. I love the nighttime activities the best, since it's when like the whole camp is together.
Until there's a cure, there's camp possibilities.
It's the week that makes.
So after listening to this, the first thing that comes to my mind was that something that I mentioned at the beginning, like I really learned about the disease in this camp, and something that all of this kid taught me was how to be resilient in life because they have suffered about this. And the other thing is that in the medical part, so I didn't know when I prescribed Lantus or I prescribed Detemir or I prescribed Novel, what was what they were getting. I knew there was insulin, but I didn't know the color of the pen or everything. And all of these kids were taught me about, you know, the purple one is Lantus, and then the green one is this one, and then the yellow one is this one. So learning, because sometimes the patient comes to you and they say, yeah, which insulin are you using? And they say, well, I don't know, but the pen is yellow. And then you remember that, so that's very important. So if whenever you have the opportunity to learn from the patients, it's an enormous opportunity to learn really the disease. So now we are going to jump from the personal experience and understanding that part from the patient to let's talk a little bit about the pathophysiology of the disease and what happened in diabetes. So that we also combine the clinical part with the patient part. So basically, we need to understand that the pancreas is the main organ that produces insulin. And you can see in this picture that really it's not the entire pancreas. It's 5% of the pancreas that have some cells that we call islet cells. And then in the islet cells, you will find that there is a combination of 3 different type of cells, the alpha, the beta, and the delta. And in that part, then the majority of them in the islet cells are the beta cells. And beta cells are these purple ones, and they are the ones that produce insulin. And here is the problem. The problem is an autodestruction because of the immune system of the beta cells that will cause then deficiency of insulin. But later on, it was figured out that also the alpha cells, the red ones, they were affected. So there is a constant communication between the alpha and the beta cells. So that's in a normal pancreas, there will be constant communication. So whenever there is one not released, the other will be released, and they will connect between each other. In a diabetic pancreas, what happened is that this communication is discontinued, and then also the alpha cells are destroyed. Alpha cell produce glucagon, and glucagon is very important for the regulation of the blood glucose because it raises the blood glucose. So that's why patients that have diabetes develop also hypoglycemia, because there is a dysregulation there, and then you are injecting some insulin, and then this dysregulation will affect the problem. We will not provide the resources for the body to respond to that insulin. So when we talk about what is type 1 diabetes, and really it's a deficiency of the beta cells that are located in the islets of the pancreas. And this is a process that takes some years to happen. And why this is destroyed? Because there is 2 main problems. One is something that we call the autoimmune diabetes, that is antibodies that are causing to destroy these beta cells, specific antibodies against the beta cells. But also there is one that is idiopathic, the minimal one, but that we really don't know what happened. And then there is destruction of these beta cells. Just to put you into context, so we talk about the autoimmune diabetes when this is autoimmune dysfunction and attacks. That we talk about the idiopathic idiopathic diabetes, where really in medicine, whenever you mention idiopathic, is that we really don't know what is happening, but also it's an idiopathic type 1 diabetes. And then there's other forms of diabetes that we are not going to get into, but the most common form of diabetes in the world, represent 80% of the diabetic patients in the world, is type 2 diabetes. There is also a gestational diabetes and other type of diabetes. And when we look at other type of diabetes, look at the list of other type of diabetes induced by infection, by medications, by there is monogenic diabetes, that is by the effect on one of the on the genes, a mutation of one of the genes. There is other endocrinopathies that can cause diabetes. There is even some genetic syndromes that can cause diabetes. So it's a big name when we say diabetes mellitus. It's not just one disease. There is multiple diseases. I always compare diabetes mellitus as cancer. When you say cancer, we are not talking about one disease. We're talking about a multiple disease on it. So diabetes mellitus is the same, with multiple, with some common things, that is the hyperglycemia, but the origin can be from multiple areas. So in type 1, 5 to 10% of the entire diabetic population represent type 1 diabetes. The problem is not this that you're seeing here. The problem is not the food that caused the diabetes. The problem is the inside autoimmune condition that caused the diabetes. And diabetes type 1, even though we know that diabetes type 2 is increasingly exponentially, diabetes type 1 is something similar happening to it. So it says that there is an average between 2002 and 2009 in this study, there was an average of 2.7% per year of new incidents of diabetes type 1. And in Europe, between 89 and 2003, 3.9% increase. So really, a lot of our focus is always in type 2 diabetes, but type 1 we have to take into account because it's growing per year. So we know that 70,000 new cases of type 1 diabetes occur each year. And if we look at the regions, it seems that as far as you go from the equator, you get more prevalence of type 1 diabetes. This is not type 2, but in type 1 when you get farther. So if you see Australia, Canada, the Northern Europe are the highest prevalence of type 1 diabetes, then the US is in the next step. But why this is happening, we really don't understand why. There is some hypothesis that says that there is some viral infection that can exacerbate the immune system and then cause the problem. And we are going to talk a little bit about that. But what we know is that it's cyclic. So it appears in 2 periods of the life. So first in the first 4 to 6 years old, and then 10 to 14 years old. But there is autoimmune diabetes can appear later in life, something that we call LADA. That is another autoimmune diabetes. It peaks more in the winter time. And definitely, as I mentioned, it was related with some viral infections that we don't understand a lot, but it would think that stimulate the immune system, and the immune system then stimulates. It's not like it's caused directly damage to the beta cell by the virus, but it's the stimulation of the immune system. So this is the theory. So there are some observations that small RNA viruses can cause type 1 diabetes. So this is unclear what is happening, but something that happened last year in 2020 is that we have a new RNA virus, COVID-19, and we have seen a lot of patients that present with no diabetes, and they get the COVID-19, and this inflammation predispose them to have diabetes after that. And some of them get destruction of the beta cells and get autoimmune diabetes. The other thing that we know is that rubella is being associated with type 1 diabetes. The exact mechanism we don't know, but there is some theories, as I mentioned, that virus can exacerbate the immune system and then cause the diabetes. There is another hypothesis that comes from hygiene, and here the microbiome and all of that is involved. So if we look at in this map, there is Finland and Russia. And we know that Finland has 6 times more incidence of diabetes than Russia. They are just across the border. So what happened is that Finland is extremely careful in preventing disease. So there is a very low exposure to many of the of viruses and bacteria in the early life. And this is a hypothesis that says that probably that lack of exposure then can predispose this population to have further develop other condition, chronic condition like diabetes. And we can see, look here in Finland, compared with the border, after the border with Russia, you can compare how the prevalence or incidence of this infection disease. Another factor is human breast milk versus cow milk. So really there is another hypothesis that the microbiome is also involved here, where patients that use breast milk will protect against developing type 1 diabetes. It doesn't mean that every person that do not take breast milk will develop type 1 diabetes, but there is some hypothesis, some predispositions, and the American Academy of Pediatrics recommend that you exclusive breastfeed with milk, breast milk for the first 6 months of life. This study, the Teddy story, is an ongoing study that has been evaluating this question about if breast milk can protect for diabetes type 1. Still, it's not being published, but we will have probably more results when we see the study Teddy published. So there is risk factors, and a little bit different from the risk factors that we get in diabetes type 2. So when we talk about genetics, diabetes type 2 is very strong genetics. So if your parents have it, you're very predisposed to have it. But diabetes type 1 is not the same. Look at the cartoon or table in the right side, where you can see the predisposition if you have a sibling or you have a mother or a father, that it's very low compared with 20 to 40% predisposition in type 2 diabetic if you have a mother or a father with type 2 diabetes. So really, this is the type 2 data, but the inheritance, it's a little bit different from one to another. There is some predisposition, but not as strong predisposition as type 2 diabetes. And let's go to the pathophysiology and talk to see what happens. So what you see here is the beta cell mass. And everything starts, sometimes there is some precipitating factors that occurs in utero. Other times you don't have that. But if you are predisposed to have this genetic, if you're predisposed to have type 1 diabetes, then there will be some genetic predisposition. Then the first 4 years of life, you have a normal beta cell mass, and then there is a precipitating event. This precipitating event can be an infection, can be environmental, and then your beta cell mass start decreasing. At the beginning, there is normal response of insulin because we have more beta cell mass than what we need. And your blood glucose, even when you reach age of 5, still normal. But then it will be a period of point where your insulin is not produced enough. And then that's when you get exposed and you develop the symptoms of diabetes. And later on in life, the autodestruction continue, and probably by the age, if you presented at the age of 6, then by the age of 9 or 10, you have no beta cell mass and you produce no insulin. But this will vary from person to person because we really don't know how much beta cell mass is in a person. And sometimes this is just a prognosis, but sometimes people develop a honeymoon phase, that is that phase where you already know that you have diabetes, but you are not completely on insulin because your body is still producing. Sometimes it can last for several years. Another person only can last for several months. So it's very individual dependent. And this is important to mention again, is that the beta cells is not equal in every individual. The reason we don't know yet. So some study has been analyzing some pancreas in the histology of the pancreas to see if there is some correlation that it can be made. Definitely there is a genetic predisposition if you in the HLA haplotypes, specifically some of them where it has been found some mutation. I didn't want to go into detail on that, but there is a lot of studies on HLA and then mutations there. And definitely there is the immune system that is the main contributor of this disease. And just jumping a little bit, nowadays there has been some studies ongoing on how to delay the presentation of diabetes type 1 by working in the immune system and preventing the immune system to respond. So some probably in 4 or 5 years we will have results from that studies, and probably we'll have a different type of medication that is not insulin to prolong the life of these beta cells. So the diagnostic criteria are very similar to the diagnosis criteria from of diabetes type 2. Here you can see when the patient presents, but it's very important that these patients the main cause is not insulin resistance, so the main cause is autoimmunity. So that there is an antibody present. We will talk some of the autoantibodies that should be present, but some patients with type 1 diabetes, not when they present early as a kid, but when they present late as an adult, they are missed because everybody thinks that adults is just type 2 diabetes, and it's not. The rate of growing type 1 or autoimmune diabetes in adults is increasing. So very important to when you suspect that the patient doesn't fit the parameter of type 2, to do the antibodies, because that will give you a little bit more hint if this is type 1 or type 2. And I can tell you that right now we are looking at the guidelines from the American Association of Clinical Endocrinology that will be published next year. And in the discussion, there was a lot of work on pursuing antibodies in patients that are highly suspicious for type 1. So these are the antibodies that we know. The most common are the first three. So the islet cell antibody, anti-GAD antibody, and insulin antibody. Usually insulin antibody will not be so much presented in diabetes type 1, up to 50% of the cases, but in a person that have been using insulin, it can develop. The most frequent one that we measure is anti-GAD, and it's presented up to 80% of the patients. So if you have a positive, you have 15% of the patients will not have any of this antibody positive. It doesn't mean that they don't have type 1 diabetes or autoimmune diabetes. So it means that they don't have this positive. So it's very important, but at least you can catch 85% of the patients that have autoimmune diabetes just measuring this type of antibodies. And this is a graph that is very important because it shows you how prevalent these antibodies are by depending on the age. So we can see that anti-GAD is a very good antibody to measure later in life if the patient starts presenting diabetes and you think that it's type 1 or autoimmune diabetes. Meanwhile, the others start decreasing in life. So they are very good if there is a kid that is presented with diabetes to measure them. But the anti-GAD is the best one to present if they present later in life. And then as we talked, so the onset is bimodal. So it means that it's 2 times in life, but then it doesn't mean that people after this 2 times cannot present it. So 4 to 6 years old is this first peak. And then the second peak, where the majority of them is in the 10 to 14 years old. What are the clinical manifestations? Really depends on the person. It can develop at any age, and usually because it's an autoimmune condition, it's related with other autoimmune conditions like thyroiditis or Hashimoto thyroiditis, with celiac in the guts, or Addison in the adrenal gland. So it's related to other autoimmune condition. Immediately you have one autoimmune condition, you can get another. So type 1 is an autoimmune condition. So the clinical presentation is very similar to type 2 diabetes. It's a person that presents with the PEES, the polyuria, polydipsia, polyphagia, and the weight loss. Usually because early in life, different from the type 2 diabetes that is a process for many years. Type 1 usually present very fast. So because then is when you remember in the curve when you don't have any more beta cells mass to produce enough insulin. So then you can present your first time with the severe complication of diabetes that would be the ketoacidosis. So this is important because then in that case you detect it. It's sometimes now what they are doing is research is suggesting that you should screen patients for when they have high risk to have type 1 diabetes. You should screen the patients. And for example, if you have a sister or a brother that have diabetes type 1, then that can start earlier, the screening, so you can detect whenever the beta cells are decreasing or predisposed to have diabetes to stop on time. It doesn't mean that we have the medication right now or a technique that will stop the progression, but then you are more prone to start the insulin early than later. And here is, I wanted to mention why insulin is so important, because insulin really is the driver of glucose into the cell. And why we need glucose into the cell? Because we need energy. And glucose is the main source of energy. In the muscle and the adipose tissue, it produces a lot of energy. In the adipose tissue, is changed into fatty tissue. So fatty tissue can store a lot of energy. So when we need it, we have, and then also the liver is very important. So there are other things that happen when we don't have insulin. The body understands, even though we have a lot of glucose outside, but we don't have insulin, the body is understanding that the patient is starving. So what happens is that all the starvation process starts. So you start degrading all the lipids in your fatty tissue. This will change to free fatty acid. Then this free fatty acid change into ketones, and then you have what we call ketosis. And ketosis later on will develop metabolic acidosis, and then it will develop what we call ketoacidosis in the diabetes. Sometimes in the past, we were using the body habitus as a classification for type 1 and type 2. Now it's more complicated because we have been seeing that there is type 1 or autoimmune diabetes that present with some obese patients. So it's not so straightforward as seeing a patient that is overweight or obese saying this is type 2. That's why the screening test with the antibodies is important, because up to 25% of the autoimmune diabetes right now, because obesity is so prevalent, are overweight. The age really also is not an indication. We know that if the age present early in life, more predisposed to be type 1 diabetes, but also we have seen type 2 diabetes in patients with younger age because of the obesity. And this obese patients will predispose to have type 2 diabetes. Also the opposite in adults, we have seen a lot of more growing and mentioned this in the adulthood about the predisposition to have type 1 diabetes and not type 2. So definitely this is a work in progress. Screening is important, and also if you start treating a patient that you think that is type 2 and it's not getting better, then you have to rethink what is the diagnosis of the patient. Of course, less likelihood in patients that have hypertension, dyslipidemia, metabolic syndrome, and acanthosis nigricans that is insulin resistant. So all of this is important. This will take to think more in type 2 diabetes, but age and body habitus, as in the past, it was saying, hey, this is type 1 and type 2. Now it's not so straightforward. What are the clinical manifestations in the skin of type 1 diabetes? And it's important because sometimes patients can present with this only, and then you figure out that they have diabetes. So the diabetic foot syndrome, you can see here, we know about this. It's even people think that it's more common in type 2, it's more common in type 1 diabetics. Something that we call scleroderma, changes in the skin. You can see this picture. You see how the redness and pinkish color there. Necrobiosis, lipodoica, that is a chronic granulomatous derm disease that occur later in life, and bullous diabeticorum, that is more prevalent in type 1 diabetes, and we don't know why this happened. Look, it's this lesion here. So there is, as I mentioned, there is a typical presentations of type 1 diabetes. That's why The classification probably is going to change a little bit. There's an article published last week about the WHO classification. There are new terms. So LADA will probably disappear and we will call them autoimmune diabetes. But it's important that not every patient that fit a standard will be or type 1 or type 2. There's other type of diabetes, and this, for example, LADA is a diabetes that present a type 1. It's a type of type 1 diabetes that present later in life. And then going to the management, it's a very complex disease. So this is not something that is just follow up by the physicians. There is a group of people involved in the management of this disease, from multiple specialties to multiple areas on the healthcare force, but also multiple areas in the social part, because family and social support are very important. It's a chronic condition, and when it appears early in life, there is a lot of things that happen, and then there is important that they have a lot of support, including mental health providers, because it's very important. So some of the things that I experienced with the kids at the camp is that usually when they get to the puberty, the adolescent, it's a normal period of life that in any person, you have some changes. These changes cause some internal physiological changes. The sex hormone cause some insulin resistance. So that on top of not having producing insulin, you need a little bit more insulin from the outside, but also it's a period in life where you want to know more about things, and then you can become conflicted with the society. And this period of time is very important to have the strongest support, because that is when many of the patients stop taking the insulin, and then the complication comes. So it's a disease that is a chronic condition that is for the rest of their life. So social support is very important, and this is something that usually the healthcare workers do not focus, but this should be the main focus of the disease. So what is the recommendation to keep the A1C? In younger population, the recommendation is to keep the A1C less than 7.5. There is the guideline from the American Diabetes Association, the guideline from the American Association of Clinical Endocrinology is less than 6.5. Usually A1C have to be individualized, but in younger population with no comorbidities, the lowest the A1C that can be is better. In populations that are older with more comorbidities, and then it's an individualized process. And here I just bring this DCCT study that shows that tiger glucose control have 3 times risk of hypoglycemia, and then 33% increase of becoming overweight. So, but this is to have to be in the context of the type of patient, because if the patient is doing the other work that is a good diet and exercise, then this can be prevented. So the main treatment for diabetes type 1 is insulin therapy, because as I mentioned, the patient has no insulin reserve. They do not produce insulin. So very important that in a normal pancreas, there is a constant production of insulin that increase 5 times during meals, but that prevents all of the things. So usually the pancreas is constant, prevent lipolysis, prevent all of that, the gluconeogenesis. Meanwhile, they're stable. In a person that have diabetes, then this is not happening. So then there is the body, as I mentioned, the other thing that is fasting. So all of this will be exacerbated. The goal of the insulin therapy is to mimic what insulin does in the body. And that's something that it's very important that we have achieved that goal, not yet with the technology that we have, but probably soon we will be able to achieve. So look at the impact of insulin. And this is the best time to talk about insulin. We are celebrating this year 100 years discovery of insulin. In 1921, it was discovered insulin, and the first person was saved in 1922. It was a kid that had diabetes type 1, and he was in ketoacidosis. So the scientists and physicians that were studying this, they discovered that there was a substance that will prevent the patient to develop. They didn't know that this was insulin, but a substance that will prevent the development and progress of the disease. And they start smashing some islet cells of the pancreas of a dog. And then they infuse this to the patient, and the patient leave. So you can see a picture in the internet of how this patient was very thin and almost dehydrated and died. The year after, he was a total complete different person. So 1 year after, we have been advanced. Look how many the life expectancy has improved, and now we are in 78 in 2021. So the life expectancy, because of the discovery of this fantastic drug that gave the Nobel Prize to the discoverers, has improved life in humans. These are the types of insulin that we have. So there is some regular insulin or human insulin. During time, it would change. At the beginning, we were using insulin from animals. Then they start making insulin from humans. And then this human insulin, they get some modifications, and we call insulin analogs. And then we will able to get a little bit more physiological type of insulin, but not yet to the point that it's the same way that the pancreas produce. But this is all the different types. There's also an inhaler type of insulin called a Freesa that is the only one that is not injectable. But what is the big problem about insulin in the US? Look at the cost of insulin compared with other countries. Even though the prevalence of diabetes is so high in our country, look at the cost of insulin, very high. So you have to have a good insurance to survive a disease like this. There is a big movement right now to decrease the cost of insulin. There has been for the last probably 20 years movements. This is the part where I think that we are more closely trying to achieve that, to achieve an affordability. The insulin is a life-saving medication and should not cost as much as it costs. In the US, a month supply of Lantus costs $600. In Europe, in Spain specifically, a month supply of Lantus costs €1. That would be like $1.5. So there's a big problem that we're having, a lot of advocacy happening, a lot of good area for anyone that is interested in this, because we need to change that. Even the World Health Organization and the US has been working in other countries to provide some of this country, Mozambique, in Central America, in Nicaragua, to decrease the cost of insulin to prevent complication of diabetes. And there's no focus in the US that also there's population that is suffering of this, and that they need to have this life-saving medication. So this is what was published in 2006, but it was a study on the world about the importance of affordability of insulin. And it was from the creating more access to insulin, but also creating communities that take care of advocacy, creating patients' education and empowerment of the patient, healthcare workers' education and empowerment of them, other measure of prevention, and definitely start talking with the pharmaceutical for increasing supplies of the drugs, in this case, insulin. In the last 2 decades, then technology in diabetes has been touching a lot. So now we have something that we call insulin pumps, that is basically a device that that will inject you constantly, and you can change it per hour of insulin. So trying to imitate that pancreas, then the insulin pump came. It's not yet still the same as the pancreas, but it's the closest that we have. Definitely there is some caveats. You have to wear this the entire time. There's infection. You have to know when it's not working. If there's kink, then it's not producing, and then you think that it's producing. So there is a lot of things behind that we have not solved yet, but at least this diabetes technology also has changed the life of many patients. The other diabetes technology is the glucose monitoring. In the past, we didn't know how to check the blood glucose. It was very, very difficult. The patient had to go to a lab and then draw the blood. But then glucose monitor came, and then it's easier to know and a point of time what is the blood glucose. If we talk about 200 years ago, the way that the diagnosis of diabetes was made is because of the urine having high glucose, and then the physicians were tasting the urine, and if it was sweet, then they call this diabetes mellitus. From that, now we have this technology that you don't have to taste the urine, but you can check your sugars and see how it is in the capillary. And then the latest technology on measurements is the continuous glucose monitoring. That is a system that will measure your glucose per 3 to 5 minutes and then give you a trend on how you are doing. Definitely this has improved the control of the diabetes. It's not for everybody, because you have to follow certain rules, and this is not the solving problem of everything, but at least it gives you real time with alerts on the management. And here I put several of this. So this is an insulin pump. So this is a glucometer. This is another type of pump we call the Omnipod. Different from this that you have to wear in the abdomen. This can be wear, it lasts for 3 days and can be wear on the arm. And this is a continuous glucose monitoring. So you can see here that there is some trend on how he's doing, but the most important thing is that you can have this in your computer. You can connect this with your physician or healthcare provider so that they can see what is happening. And these are the components, very simple components of an insulin pump. You have the insulin that you will put in this vial or reservoir that goes in this machine, and this machine is connected through this tube. This is the part that goes in the abdomen, and this is how you put that in your abdomen. So very simple, something that is coming soon. The new insulin pumps and CGMs are connected with between each other. So tell the other what to do in some kind of sense. Something that is coming is the bionic pancreas that will have an insulin pump, a glucagon pump, making the work of the alpha cells and the beta cells, plus a continuous glucose monitoring that will regulate it. So that's a hope that will be. There's several studies that have shown very good, but we don't know how that will work in real life. But we're expecting there's a lot of hope there. Just to end this, nutrition continue to be very important, even if it's not the main cause of the problem, continue to be very important for type 1 diabetics. And definitely alcohol, it's reduced hepatic glucose, and this can produce hypoglycemia. So avoid alcohol as much as you can. It doesn't mean that you cannot drink anything, but you have to avoid. For patients with diabetes type 1, it's important to keep ketones strips at home, because whenever you are trying to develop this symptoms of ketosis, or you think that your sugar is high and all of that, it's important to see your ketones, because if you are ketones, then it's recommended to inject more insulin. In the diabetes camp, the ketone strips are in every bathroom. So and the kids know when to measure, and if they measure, they come to us and say, hey, I am ketone positive, and we give them water and we give them more insulin, and we prevent diabetes ketoacidosis. Surveillance, it's important in diabetes type 1, different from diabetes type 2, that retinopathy, probably it starts 5 years after So to start screening the nephropathy 5 years after with microalbumin, and the neuropathy, definitely food exam is mandatory, and monofilaments is what we use. These are the points where you should look for sensation, and then there's other tests with vibration and things like that. And definitely this, I want to end with this before the summary. I want to end with this several quotes. One is that we are celebrating this month is the Diabetes Day coming soon, but it's not one day of a month. It's the entire year that we have to make awareness of this disease. That is one of the most prevalent diseases in the world, combining type 1, type 2, and the other diabetes. But it's very important that that we are aware of them. My pancreas gave up, but I never will. So it's very important because we have to continue stimulating those patients to have the strength to continue with their disease. We have to support this patient, not just as a physician community, but also as a society for them, and as a scientific community, trying to discover every day something new to make the life easier for patients with diabetes. And finally, a quote from Brett Michaels, that I accept that I have diabetes and I'm not going to let it run my entire life. So a diabetic patient, the main thing is not thinking the entire day about this disease, is trying to be partner with the disease, knowing that it exists, knowing that you can be better, but it's not trying that disease to rule your life. So in summary, we talk about antibodies, different antibodies that can trigger diabetes type 1. We talk about the management is multidisciplinary. There's new technologies, there's new that helps in the management, but definitely integrating everybody, including the society. We talk about trying to learn about the disease and having experience. If you don't know any diabetic patient, to talk to them and ask them what are the main concerns. And when you go to the hospital, definitely dedicate part of your visit to understand the patient and do not assume things, because sometimes we are biased with the disease, a lot of bias with the disease. Always say, oh, you're not eating good, but we have to address other things. Social determinant of health is very important in this disease. And definitely trying to prevent the complications that can be microvascular or macrovascular complications. So with that, thank you so much, and turn to Dr. Hartmark-Hill.
Thank you so very much, Dr. Correa. I hope you'll see some of the comments and the appreciation in the chat. I'll also be monitoring the Q&A in the chat for any questions. And while folks are thinking about their questions, I just want to kind of return to the statistic and the evolving data that you shared about one of the many potential complications from COVID-19 virus as an RNA virus being the incitement of, or setting off the autoimmune process that leads to type 1. I'm very interested to know, what are some of the projections, or what are you and other experts in the field seeing as trajectories? Because it seems like this is kind of falls into that acute on chronic type of situation. We know that incidences, prevalence has been increasing, and then now we have this pandemic exacerbation. So what are you and your colleagues predicting that this will mean for the patient population?
Yeah, so that's something that it's right now there is a big multicentric study where University of Arizona is one of the centers to understand patients that didn't have diabetes, why they develop diabetes with this virus. Not just type 1, but type 2. We have seen a lot of patients that have type 2. So the big issue that we have not going into deep into research, and that is very important, is the long-term complication of the COVID, if that also affect the development of diabetes. So it's not just the acute phase that we know there is a lot of inflammation that can stimulate the antibodies and all that, but also the long-term that what we call the long hauls of COVID, what happened in that case. So that will be something very interesting that probably soon somebody will be starting, but seeing how that virus that we thought at the beginning that just affect the respiratory tract, it's now changing to more chronic things that we never expected. And one of the things that we never expect was this, the diabetes. So the first thing that we started seeing was patient that came to the hospital with only using, these were more type 2 diabetics that were coming to the hospital with only using metformin and another medication, getting to use 500, 600 units of insulin during the acute phase of the disease. And some of them, we report something in some 5 cases from Peru, where they came to the hospital and they developed ketoacidosis after the diagnosis of COVID. So very severe complication for something of a virus that we thought that always was respiratory virus.
Yeah, absolutely. A very strong inflammatory milieu that we'll need to unpack for years to come. Karen in the chat, thanks you, says this has been super informative. She appreciates all the work that you do. She's on board as being a registered dietitian for the past 20 years and admits that the statistics are sad, but thankfully that we're working towards the same goal. And she had also shared that her sister, who was very healthy prior to this, developed a post-COVID a diabetic picture, but it seems like it might be resolving. So, you know, maybe a transient, I don't know if you can say more about that, if we're seeing, and that may be part of what you're saying, we don't know the long-term, you know, the natural history of this, who will have it permanently and who will have a transitory manifestation.
Correct. And the most common one is the transitory. So when they have the acute phase, there is a lot of inflammation, the insulin receptor there is beta cell destruction. In that period of time, this is happening, but what I've seen is that then the patient recover, the inflammation goes down, and then all the other complications disappear. But something that we don't know, because there are some of them that continue to have diabetes. And then there is one patient that I have that start presenting diabetes 3 months after the patient got COVID. Why this happened? Okay, at this time we were blaming the COVID, but because there was no reason that why the patient should have diabetes. But then you start looking at what some other RNA virus cause, and then you see that there is a predisposition on a patient that already come with a predisposition to develop diabetes. So, and rubella is one of them, and then others that has been described. So COVID is an RNA virus. So
I think one has to hope that in that is a silver lining, that we're going to learn a lot more about the interactions, and perhaps that can be leveraged into a cure. Can you speak a little bit about what you're seeing on the near future horizon in terms of some of the most promising research that could be possibly curative?
Yes, so there is I think the most promising study is working with immunomodulators to prevent the development of the diabetes. The big problem with this is that you have to detect patients that are at risk very early, so you can prevent the production of the antibodies and then the destruction of the beta cells. So it will have to be, and you cannot screen everybody, so it has to be a congestion, but it's very promising. The survival of the beta cells has been very exciting. Then the behind the scenes research has not been published yet, probably in 2 or 3 years from now. The other thing that was a little bit promising but didn't work well was in the 2000s. There was a study that started analyzing the islet cells transplant into other part of the body, specifically the liver, and to put this cells to produce insulin. The problem is that in reality, when this study were transformed to reality, it shows that really the islet cells do not live a lot outside the pancreas. There were, yes, the patient goes the first 2 years without insulin, but then those islet cells start dying again. So what's not, there are some centers in the US. I had the opportunity to be in Miami, and then there is a center that do this, and I was able to see how do you transfer that, but has not been so promising as the one that is not the patient that already have it, but the patients that we can prevent to have it with immunomodulation.
So here's a question in appreciation for the person-centered, patient-centered approach that you're really encouraging. Can you speak a little bit about how you talked about how volunteering with groups like Camp Possibility really fosters empathy? Can you share some stories of how, like, what impact that's had in your work when you're back here in Phoenix in the Valley in your practice?
Yeah, so definitely I think that having exposure and understanding, and then living with people with those kids that have diabetes, change the entire perspective, and then make you more aware of things that you didn't know, and make you more aware to advocate for those patients. Usually in medicine, we look every time, like as a physician, it's difficult. It's you come, a patient comes, you prescribe. That's it. You don't, I think that we are lacking behind of understanding how is the disease, unless you suffer from the same disease. That's why the endocrinologists or the physicians that suffer from diabetes, they are more aware of many things that the others are not. But having the experience with patients, and it doesn't have to be diabetes, it's applicable to any other disease, and understanding how they live, what they do, how they survive, what is all the things that they have to do with living with a chronic disease is very important. And then that creates you more the area of, I want to advocate for them. I want to be a different person. I want to, even if I don't have it or I don't have any experience, you see that you think about type 1 diabetes, look at the kids that say, I am the only one in my school. So it's not a lot of kids that will have, but being an advocate for them, and how it's getting involved. If you are in the healthcare system, in any healthcare organizations that are doing this work, from local to national. The second thing is, there is a lot of pressure at this time, talking to your, if you don't want to get involved in organizations, then talking to your legislators and telling them they don't understand. There is the same, they are not aware. So talking to them, creating coalitions or organizations that help this. There is the GDRF, the Junior Diabetes Research Foundation that have a lot of things, and talking to your to where you work, to your hospital, and creating partnership. I think that there's many ways that we can advocate. At this point, really the main focus has been the advocacy for decreasing the cost of insulin. That is a life-saving medication, but many things will come. And then also thinking about those that do not have access to care and suffer from this type of conditions. So always thinking about the type 1 diabetic that is an undocumented immigrant that came to this country, how that person can survive. The ones that do not have money because they cannot afford, you have to afford or insulin or food, which of the two? And then even there is a black market in about selling the strips. Probably you have seen in the street, like, hey, we will buy this because the strips are so expensive. That's another thing that is so expensive. $50, 50 strips, and you need to check 4 times a day. Imagine. So all of that kind of things. There's a lot of work to do from the inside of the healthcare system, but also the outside of the healthcare system, to make people realize. I think that if politicians understand how much these people suffer and how much they spend, they will be different. But the only way that they can understand is that somebody goes to them and tell them the truth.
That is absolutely correct. And stories really move hearts and minds. There's a comment in the chat that is very much in line with what you're talking about, advocacy and coalition building. So Julie Hoffman, who's going to be on the panel next week, says, Dr. Correa, the Arizona Diabetes Coalition and Leadership Council look forward to learning more from your thoughtful, patient-centered insights. Dr. Z is already a favorite. So some new opportunities to build some more networks and more coalitions. And of course, we hope that this is part of that ongoing work, raising awareness in our future health professionals and encouraging them to really be the patient advocate and to know who the person is who has the illness and meet them where they're at. And it sounds like as we have new emerging therapies, there will always be the need for the health equity advocacy and coalition building. So thank you for the work you're doing. It looks like we have some more thanks, this time has been wonderful. As we're wrapping up, I want to invite Dr. Zirulnik to come on too. And if you want to share a little bit more about upcoming events, because this is a series, we don't want this to be one, we want this to spark ongoing dialogue and continue the conversation. So Dr. Zirulnik, can you tell us a little bit more about what people can look forward to next week?
Sure.
And before Dr. Zirulnik, I really want to thank both of you, because this is what I was talking about. This is advocating by teaching. This is advocating by showing this amazing exposition that hopefully everybody can go and see it at the UFA college, because this is way that we can make others realize, like when you see all of those syringes, you can think like, oh my God, Michael, how much do you inject yourself? If you were thinking that taking one multivitamin per day is a lot, and people complain of taking this, imagine injecting 4, 5, 6 times a day. And that brings you to your mind that this is a story that you should tell and take pictures and then express to others. So this, I think this is amazing. Thank you.
Thank you, Dr. Correa. And thank you for presenting tonight. I noted in the chat while you were speaking that in the almost 30 years now that I've had type 1 diabetes, I learned more about my disease in this last hour than I've known in all that time. So thank you. And that may say something about me too, not reading as much about my disease as I should in textbooks, but it really was insightful and powerful, and I felt empowered by it as well. So I appreciate it. And I'm so glad that we're recording this so that we can share it with the public and other students and providers as well. To speak to Dr. Hartmark-Hill's question about upcoming events, I popped a link in the chat, and that is a link to next week's panel, which is geared towards the public. We are going to try a hybrid in-person and online for those that want to come in person. 5:30 to 6, we'll have a modest reception, and then 6 to 7, we have some additional amazing great speakers. Ms. Julie Hoffman, who is on this webinar with us, joining us this evening. Thank you for being here, Julie. She'll be talking about diabetes and access and advocacy. Dr. Dorothy Sears at ASU, who was previously in San Diego, talking about really fascinating research that she's been doing for decades now, and what she's learned and how we can apply it. And then Dr. Gabe Scheibe, who just won, I think, a $10 million NIH grant, which is about community. I won't do it justice, but it's about going out in the community and working with the Latina, Latinx community here in Arizona and doing outreach and prevention and education. And he'll be speaking from that angle, that lens, and some personal stories and narratives. And so I'm really excited and looking forward to next week. And I'm glad that we can use art and narrative and stories as a conduit to have these conversations and bring together so many individuals from various parts of the world and professions who don't necessarily have the opportunity to get together and talk about something like this. And I think that's the power of the humanities and the arts, is it brings us to a place where we can all gather. And to Dr. Hartmark-Hill, thank you to you and your support and your advocacy and your work and your dedication, and also for supporting this, sponsoring this, with narrative medicine, and just being a great partner in this and doing the good work that you've done for a long time, and I know you'll continue to do. So thank you.
Thank you all. Just such a privilege to do this work, and so inspiring to have so many people bringing awareness from different angles. So really is community building. And I think we all can do so much more together. And those connections that we have with each other are so healthy too. So this is all about health and wellness, and how we connect and support one another is a really important component of that. So thank you all. I wish you a good evening, and we hope to see you next week. Take care, everyone. Good night.